Good morning, good morning, good morning. Here it is, August already. It was just July.
Time's flying. It's a weird year.
August the 5th, is it not? The 5th?
That sounds right. 6th maybe?
Fifth?
6th. August 6th.
August 6th.
Yep.
See, I've already lost a day again.
It's happening a lot.
You know, I used to laugh at elderly people who didn't have a job and they were home. They didn't care what day it was. And now I'm trying to think, what day is this? You are giving yourself a break by not staying home all the time.
Mm-hmm.
But we've discovered a neat way to do this thing.
What's that?
We have a sign on our refrigerator. It says, we are not confined to home. We're not trapped at home. We're safe at home.
Mm-hmm.
And we've been doing a lot of Netflix series. We just started House of Cards.
Oh, that's a good one.
And we just finished
really
Madam
good one.
Secretary.
Mm-hmm.
And we did 24 with Kiefer Sutherland. And we did From the Earth to the Moon with Tom Hanks. And we're pulling them off. It's been great, you know. But
great. Pat, remind me, do you do the show every week on Thursdays, or is it just the once a month?
Every week.
You do it every week.
Thursday,
Okay.
yes,
All right. So last month when I was here, I did it with Dr. Johnson, but you've been doing it in the meantime.
Yeah,
Gotcha.
9.5 years, I think.
9.5
I've
years.
been on the air, yeah.
Wow.
I was trying to get somebody else to do a show next week, and their corporate structure says they can't do it unless they get a corporate person coming down to. I said, fine.
All the legal things.
Let it go. Let it go.
Administrative.
Mommy
It's
says
ruining,
you can't do it.
It's ruining a lot of things.
I
Just
know.
look at medical insurance and government's role. I mean, it's really just tying doctors' hands. Unfortunately, I don't make the decisions. The insurance companies do. But we just do the best we can to try and help the patient despite what the insurance company wants them to do. And yeah, it's a very frustrating process, but it's one of those things. It is what it is. And
I'm one who gets in trouble verbally for the things I say, and I'm going to get in trouble on this one. You know, I believe in my government. I believe in the things. I love the idea of Medicare, that you know, at a certain point in time, you get rewarded for your work and everything. And yet, I think there's I hate to say it, a plot on Medicare. People are saying, we're not going to touch Medicare. We're not going to change Medicare. We're not doing anything. No, they're not. What they're doing is every year they're cutting back on the reimbursement.
Yep.
And there will come a time when your business puts a sign up, we do not bill Medicare. We will give you the bill. You bill Medicare.
Yep.
Because the $230 you pay up front. Now, Medicare will reimburse the family or the person for $67.
Yeah, it's unfortunate.
Because you can't practice. Given the 9, 10, 11 years that you put into your training and all of that stuff. And, and being an intern, you're a slave.
Yeah.
You didn't sleep very much.
It's very true. Yeah.
And so you should be rewarded for the kinds of things you're doing, plus the service you're providing.
Yep.
And I think every year they cut back. As a case in point, I believe this is true. My wife's business, the doctors, stopped doing Medicaid testing. The test takes 45 minutes. And Medicaid was reimbursing something like $16 for a test. And it costs more than $16 for they have to send the secretary to prepare the paperwork and send it.
Yep, exactly.
So they said we can't, and they did a lot of charity work.
Yeah.
And it should not come to that. But see, we're
It's
telling
an
people.
unfortunate reality, though.
Medicare's not changing.
Yep.
You
They're
still
not.
have it.
Yep. Well, hey, Pat, before Dr. Johnson calls in here, he's about to call in a minute or two. For those people who don't remember me, I'm Dr. Joe Wiersbicki, and I am one of the non-surgical specialists here in town. And I work with Florida orthopedic specialists. And we have 2 offices, one in Port St. Lucie and one in Stuart. Our Port St. Lucie office is off of Highway 1 and Walton Road. And our Stuart office is close to the intersection of Highway 1 and Indian Street in Stuart. And you can find us. Our telephone number is 335-4770. If you want to give us a call and come in clinic, that's where both Dr. Johnson and myself work. And Dr. Johnson is actually going to be joining us now too. Dr. Johnson, welcome. How you doing today?
He's on the air.
I'm doing well. Thank you so much. Good morning.
Morning. And you haven't met Pat before.
No, we haven't met Dr. Johnson.
But I've talked all about him to both you guys.
Oh boy.
You got a good thing.
Well, you got good things from him about you, but not about me.
Well, yeah, Dr. Johnson, I was just telling people about some of your training and your specialty and in basically the leg, the hip, the knee, the foot and ankle, and your training at Columbia University and in the Navy and all that good stuff in between. And yeah, I was telling everyone that you could find both of us at Florida Orthopedic Specialists. And yeah,
Columbia
I thought I caught you up.
77th Street.
Let's see, it runs all the way up from 85th, and then the northern end, I think, is actually way up by 110th now. They took over all those blocks, and they've been expanded, so they're all over.
I had a friend a college friend, a fraternity brother, actually, ended up teaching at Columbia in audiology.
Oh, wow.
And I went to visit him in Upper Saddle River, and he said, "Come on to work with me one day." And we're going over the George Washington Bridge, and he took this little thing out of his pocket, looked like an extended pencil, and put a 22 caliber bullet in it. Put it back in his pocket. On the way home, he took the bullet out as he was going over the bridge.
That Boy Scout motto: always be prepared. Right?
Yep.
Well, it's like, I had one of my clients was a New York City gentleman, probably in his upper 70s. And he said, "I've been lucky to live in New York City. I only got mugged 3 times.
Jeez.
That's true. I think New York at one point was a standard par 5 for money.
Yeah, you could get an eagle if you were really good that night.
That's right.
No, I love the city. I lived in the other New York, Western,
Oh, sure. Yeah.
the land of lake effect.
Lake effect, right? I was just about to say that's some epic snow out there. I remember seeing some pictures of snowdrifts going up to second-story windows and so forth. That's pretty bold living out there for at least for a couple of those seasons. I'm sure.
All right, one more point that would get to your knee. I was lamenting to a friend one March, and I said, "Gee, we had 10 snowstorms," and he said, "No, we only had 3." I said, "Well, what were the other 7?" He said, "Lake effect." I said, "Well, tell the difference to my snowblower, because we still got 3 feet of snow." But we were 6 hours away from the city, and we would get home on Friday, 5 o'clock, jump in the car, be in New York City by 11:30,
Wow.
have a nice lunch, go to a Broadway musical, drive back on Sunday again. So it was easy for us. It was available to us.
Yeah.
There's nothing like it. There was nothing like it. I don't want to see it today.
No doubt.
Well, hey, Pat, before we got to your question about kind of some of the knee treatment, I wanted to ask a question, Dr. Johnson, about a podiatrist, because Dr. Johnson is specialty trained in foot and ankle surgery.
Right.
And so, sometimes people will ask me, well, is this, I got a problem in my foot or in my toe. Do I go to my podiatrist? Do I go to an orthopedic foot and ankle specialist? So I guess, Dr. Johnson, how are you different than a podiatrist? And what do you tend to say, are more podiatry related issues versus what are more orthopedic surgery,
Good
foot and
question.
ankle? Yeah.
Sure. Yeah,
How do you
absolutely.
tell
Very
that
common question, and I think, certainly from the outside, I'm sure our specialties look pretty similar to a lot of folks. I think the difference is a little bit in terms of the training. So obviously we go through, as foot and ankle orthopedists, the standard 4 years of med school, 5 years of orthopedic training, and then an additional year of that subspecialty training. So I think we approach things a little bit more from a medical standpoint. Whereas my understanding, not having gone through it, of course, the podiatry training is obviously a little bit more limited to the foot and ankle, and a little bit less to the general medical side of things. And so I think our approach may be a little bit more holistic in terms of keeping some of those other factors in mind. There is certainly a lot of overlap, to be fair, and so I think a lot of the procedures that we do are similar. I think for us as orthopedists, we do a little bit more maybe of the bony work, especially as you move more towards the the midfoot region, that sort of apex of your arch, the hind foot, sort of the heel and the area underneath the ankle, and then also allows us to work a little bit higher up on the leg as well. So things like the shin bone or tibia, a little bit different approach, I think, to ankle fractures. I'm not sure that all podiatrists do those. And perhaps an area where there's a little bit more of a leaning towards podiatry has been, I think, a lot of the soft tissue care, nail care, those types of issues. Not that we don't do those things, but I think that they're probably a little bit more of their routine is involving some of those things. So the diabetic foot care, for instance, is certainly shared, but some of the routine maintenance, the trimming back of the nails, looking for ulcerations, taking care of calluses. I think those things, especially that podiatrists are probably a little bit more common in terms of their activities. And so I think that's kind of the main difference. Certainly there is a fair amount that we both do together, things like bunions and hammer toes, all that sort of work. But again, I think maybe our approach to those things might be a little bit differently informed based on that difference in training.
Yeah.
Right,
Oh,
right.
great. Yeah,
Yeah,
that answers a lot of my
That's good.
question
That's
there.
a good-
Yeah. Yeah. And especially when I see those bunions, and a lot of people say I need to go and get evaluated by the podiatrist. Sometimes I'm steering people more towards Dr. Johnson in those scenarios. Not that there's anything wrong with the podiatrist handling them, but from what Dr. Johnson was talking about, they tend to handle them in a little bit more holistic way, where you consider the rest of the foot and maybe some long-term consequences and more proper procedures. I don't want to say anything wrong here, but
and you're on the right you're on the right track here. A number of patients, including myself, want to know more than what is on the wall when I go see a physician
Mhm.
or a specialist. I want to know, are you board certified? Could you give me a couple names of patients that you
board certification is important. Yeah.
And they look at me like, what? See, I'm dangerous. I know a little bit about medicine, but it's my body, it's my thing, and I want to make sure. I scoured the area for open heart surgeon 16 years ago, and I found one of the best out of Palm Beach Gardens Hospital for this area. And I wasn't going to settle for anybody else. Because I had
point too. Yeah, you're certainly never wrong to get things like a second opinion and to do a little bit of homework. And I agree with you. As a physician, I'm always sort of prepared to answer those kinds of questions. And sort of lay out where my training has been focused and so forth. Just because you're right, it's your body as a patient. I don't think people want to be told first off, what to do, which is very reasonable. I'm here to make some recommendations and give you the ups and downs of things. But at the end of the day, as much as I want every single one of my patients to end up, better than when we started, there are things that can happen. There are risks of any surgery. There's risks of any treatment. I think someone who can go through that with you with, the care and caution that's required and help you to make that decision, whether those risks are worth taking to try to get the benefits is always a process.
Right.
Oh, yeah.
And I would follow through with Joe's suggestion if he recommended I come and see you because he knows your work, not your shingle.
Good.
Yep.
That's true.
Yep.
I'm sorry, because there are a lot of people out there that are saying that they might be a cardiologist and they're not. They're not trained. And like I said, it's our body, and I particularly appreciate one of the reasons why Joe and I got together is when he was doing a routine visit of mine, an annual for my back.
Yep.
And we got to talking, and I thought, this is the guy I want. He's a human being.
Right.
He has. He's a good conversationalist. And what does that have to do with medicine? It has everything to do with it.
Yep.
I have a cardiologist. I walk into the room, and he says, "Okay, tell me, when did your cruise last?" And then his wife is from Norway, and she goes up about every 3-4 months to visit her family. And he'll fly in for a couple of days, come back again. So we compare trips in 3 minutes. And now we're both relaxed, and everything is fine.
Yeah. And I think you find that personality trait with everyone that Dr. Powers has recruited, with our practice, with Dr. Forrester and Dr. Johnson here, we're real people and we take the time, it's not one of those big corporations where we're just trying to, push people through. And, I say out of my experience with all of our surgeons here, they're not cutters, how you hear about people saying, all this surgeon wants to do is cut.
Mm-hmm.
I really don't see that with our surgeons here. And I'm so proud of that.
Well, Dr. Powers started off with being the best and setting up an organization, bringing in the best.
Mm-hmm.
He didn't just start a practice.
Yep.
He started an expert practice for all kinds of things. Plus, you have rehab right next door in the same building.
Oh, yeah. Rehab, MRI, we got the ultrasound, the administrative offices, the surgery center that they do some surgeries at next door.
Yep.
Yeah. Oh,
yeah,
wow.
Dr. Forster did a couple of my surgeries. Yeah. And the thing is, we're all working together. We're all working together, and you see a patient, you're going to refer him to Joe. Joe sees a patient, going to refer him to you, and both of you right away know what needs to be done and how well it's going to be done. And
You're absolutely right there too, and I think also that notion of building a relationship with the patient. We're kind of the patient, the physician, and the rest, the physical therapist, all of that, working as a team to try to get this patient better. And I never want patients to feel like they have to tackle these things on their own, or that they're going to be kind of shut out. I want them to have ready access to us as their team that's trying to help them to get better. And I think that goes to that. Like you say, Joe, we're not, just cutters. We're not a factory. We're really looking to try to make sure people feel comfortable with their care and they can, feel like they've got access to us to get that information and that,
right.
Something's not going quite right. Well, how do we get you back on track? I don't want you hanging out for 6 weeks waiting to get in to see me. Let's tackle that problem right away. Let's get you in and get you taken care of.
Yep. And that's it reminds me of one of the things Dr. Prowers says about the practice is that it's university orthopedics in a community setting. Everyone in our group is fellowship trained, board certified in their various parts of orthopedics. But we approach it in that community way. So I really like how he says that.
That just keeps the pressure down. You have a much more relaxed environment to work in.
Mm-hmm.
You're not competing with each other. There's no backstabbing and things. I know the rehab portion much better. I was a rehab director, and I stirred up some trouble with PT, by the way, because I'm a trained SLP, speech language pathologist, and we rely on measurements and data as much as we can. And a lot of times, I was a rehab director in a nursing home, and it really shook everybody up because I got all the PTs together and said, that when the patient reaches maximum potential, we discharge them. Now, you have to prove to me that the patient is reaching maximum potential. Okay, well, our goal was 150 feet ambulation, got up to 138 feet twice, so we discharged him. So wait a minute. How long did it take him both times? Did you measure the time? Oh, no. Well, guess what? The second time was twice as fast. Is that potential for progress? Yes. Even with OT, hand to mouth, feeding. How long did it take from the spoon to the mouth? Not just the independent act of doing it, but measure it, chart it, and it will continue to draw therapy until you reach that maximum potential. It's quantifiable.
Hey, Dr. Johnson, how much do you deal with amputees and the devices and kind of their care? Is that a major part of your practice? I'm actually not too familiar with that. Just thinking about functional things here.
No, it's a great question. I think certainly they've been trained in those, and have not seen as many folks in this area that have had that need. But it's definitely an area where we work very closely with the prosthetic folks who can certainly keep updated and modify existing prostheses, or in those cases where folks are new to that, let's say a bad diabetic infection, what have you, and sort of needs to be fitted with those. There's a little bit of kind of not passing of the baton, but certainly a reaching out of hands to make sure that their end of things, the prosthetic is working well with the patient's sort of actual limb, and that their function is improving appropriately, that things aren't changing. And that's the other aspect too, is obviously the prosthetic is kind of a fixed device. And if the person's leg should change, let's say a little larger, a little skinnier, different pressure points, all of those things need to be taken into mind. And so making sure that there's a good communication line there. So I think I'm kind of that end of that interface. But as I mentioned, not as many down in this area that I've encountered at this point. But certainly I'm sure they're out there. And if needs arise, we're well capable of managing that.
And I'm sure that last surgery you want to do, but I'm sure you do, is when you have to do an amputation in the hospital because of a bad foot infection or a knee infection or whatever. That's something that you do and occasionally have to do, right?
Yeah, it is. And you make a great point. I remember actually during my training, speaking with one of my mentors at the time, and we're doing one of those amputations for that very reason, bad diabetic infection, and just kind of, this really feels like a loss. He's like, yeah, I know what you mean. It's not the surgery you want to be doing, but then remember too that this patient hasn't been able to put weight on this foot in any real, significant capacity, functional decline, all the limitations that start to come with that, the risk of, infection spreading and so forth. But by doing this procedure, in about 8 weeks, they're going to be able to be fitted with a prosthesis, and then, in a couple of months, they're going to be up and walking again, and their quality of life is going to be dramatically improved. Whereas right now, they're sort of, rearranging deck chairs on the Titanic, and it's going down,
Yep.
So you put it in that perspective, and even though it is, you're right, it's not a surgery anyone looks forward to having to do. It is sometimes the beginning of a much better, quality of life, and so it does help to put it little bit of a positive spin on an otherwise,
Well,
pretty
It's
dour
like
situation.
with
Yeah.
the younger patient, they don't walk, they run now.
Yeah,
Those new
yeah, that's right.
devices.
Yeah.
Yeah.
I saw a kid was bilaterally amputee, both of those devices, and he was running faster.
Faster, right?
My
Yeah,
God.
there were. They actually had to. I mean, I don't know the current status. I guess I'm talking a little bit outside my zone, but exactly that, because the prosthetics or a runner who was in a competition was actually faster, and they had to
Yeah.
qualify him in a sense because it was almost unfair to the other runners. That's how fast they're moving now.
Well, let them be a bilateral amputee and get in line.
You hardly think, but it's unbelievable. And those technologies have advanced so much too. I know through the military we saw a lot of the early the sea leg stuff, the robotic controlled lower extremity prostheses, and they're all far more sophisticated now than they used to be. And you look at sort of the very clever mechanical adaptations they used to use. And a lot of those now have been even sort of further refined with the use of robotics, electronics, different types of sensors. It's pretty staggering what these things can do now.
And there'll be better coming.
Yeah. Oh, yes. Absolutely agree. It's staggering. That technology is rapidly progressing, and that's where sometimes having a good prosthetist is so helpful, because they're up to date on all these things, and so you think you know what's going on, and 6 months later there's something brand spanking new out. That can even improve that patient's quality of life further. It's amazing.
Hey, Dr. Johnson, that reminds me. So people with a chronic foot drop, occasionally I'll hear about a new device that helps to activate muscles. And have you seen? How are you treating foot drop now? Are there new things out there, or are we using still the standard kind of AFO still, or how are people dealing with that?
There are some that are working now to try to recruit other muscle groups now and see if they can kind of reconstitute some of that strength. I haven't seen a lot of that just yet. There is kind of the latest generation of that ankle foot orthosis, the AFO, where they are using a little bit more of that sort of dynamic spring effect. And so it's actually a more normal gait for a lot of folks.
And is it not as irritating to the skin? Because that's the common complaint I hear with the AFO.
Absolutely.
Yeah.
Yeah, and that's the nice thing about this one. So there's a couple now that are using sort of carbon fiber and similar technology, so they're much lighter, and they can be much less constraining. It used to be that sort of solid plastic shell that went down the back of the leg and along the foot. Now there's sort of more of a calf, cuff, if you will, kind of a component there, a very thin, slender carbon fiber, usually connection to a foot plate. And everything in between is able to be kind of open air and exposed. So it's a much smaller connection between those, but provides great stability. It's, as we mentioned, very lightweight. And of course, we live in Florida, so you really want the least amount of stuff, wrapped around your foot and ankle as you can kind of deal with, especially during, summer weather like we're having now. So I think it's a very different feel. A lot of people who have had the old style are very reluctant. And then we sort of show them some of these newer technologies. They try them on, and I think they're really quite surprised about how much more comfortable and functional those things can be.
Speaking of that, Brian Mast, who is our representatives to House of Representatives of Washington, is bilateral amputee. He was a demolitions expert in Iraq, and he was defusing a bomb, and it blew up and blew off his legs from his knees, both of them. And of course, he has prosthetic devices. And I interviewed him. He was up in his office in Washington. And it was during the elections, and somebody said, well, you can't just have one candidate on. I said, I just want to know things that nobody ever asked the candidate. Like when you got off the plane, was somebody waiting for you there? What office did they give you? Where did they take you? How did you go? Were you afraid?
Yeah.
And I said, Brian, you're a mystery to me, because you're a guy with both of his legs blown off. Most veterans end up being alcoholics or drug addicts to cope. I said, you went to Harvard. And I said, why'd you do? He said, look, I wanted to serve my country. And the only way I could do it was politically. Now. And I said, how come you wear shorts all the time? Are you playing up your handicap? And that's not a question you ask a handicapped person. And he laughed and he said, no. He said, the devices that I have rip long pants at the knee. I kept getting holes in my long pants.
Oh, no kidding.
So,
there you go.
Interesting. Yeah. Is he above the knee amputation or below the knee? Below the knee? Do you know?
I think below the knee.
Below the knee.
I think so, but I apologize. I don't know for sure.
Yeah.
Yeah.
I'd say I was at National Naval Medical Center, Bethesda, which has now become sort of the new Walter Reed. This is obviously many years ago now, but this was sort of during the upswing on the Iraq War, most recent one, and we had to see, unfortunately, a lot of the folks, these kids, 18-year-old, 20-year-old, coming back with these sort of, as you mentioned, these horrific, sort of bomb blast injuries, and some of the technologies that have evolved to actually be, not that anyone would willingly, choose to pay that price, but at least being able to, again, put a positive spin on something otherwise pretty negative. But learning these new ways to kind of help these really severe extremity injuries and doing things to help try to regrow segmental bone loss. If you lose a piece of, let's say, your femur, you've got the far end and the near end, but everything in between is gone.
Yeah.
They were working on ways to kind of regrow that and stimulate normal bone growth. And of course, the amputees were a huge part of that as well. And just extremely, first and foremost, humbling. And actually, you mentioned Brian and what he's done with his life, and that's just, again, it blows your mind that someone could be, dealt such a tough deal with the cards and yet still, turn it into such an incredibly positive life and career. Just,
well, we have to give him credit because he got a bill passed. It was a bipartisan bill to divert the water from Lake Okeechobee south.
Oh, yeah.
And it took 40 years for that bill to be passed. Now they don't have the funding yet, but that's the biggest obstacle was to get that done because the Army Corps of Engineers was not going to do anything unless there was an order to be done.
Of course, yeah.
And that's going to save us on all of that the sludge and stuff. In the St. Louis River.
Blooms and all,
Yeah, so that hopefully will take care of it.
Well, I tell you, you utter the word bipartisan and government in the same sentence, and that's a heroic achievement right there.
Sometimes that's an oxymoron, though.
That's right.
All right, Dr. Johnson, we're going to take a little break here for a few minutes, and we'll be right back.
All right.
All right, and we're back here on the forum. There
And
we
Pat,
go.
let me give people our information again in case they were wondering how to find us. So Dr. Johnson and myself, Dr. Joe Where's Becky, Dr. Paul Johnson, are with Florida Orthopedic Specialists. You can give us a call and come in and see us at our clinic at 335-4770. Again, we have the office in Port St. Lucie off of Highway 1 and Walton Road, and our other office near the intersection of Highway 1 and Indian Street in Stewart. Or you can find us on the web, floridaorthopedicspecialist.com.
Right.
Yeah, and what were we talking about over the break here?
You were talking about picking his brain for
The knee treatments.
Knee
Yeah,
treatments.
so I do a lot of injections. I'm kind of the cortisone guy because I'm the non-surgical specialist of the group. And I was telling Pat that when someone needs a knee replacement, oftentimes I'm sending them to Dr. Johnson for that muscle sparing procedure. And so I guess we just wanted to, Pat, did you have a specific question about kind of the knee treatment? And I guess, let's turn it over to you, Dr. Johnson.
yeah, right.
Knee arthritis, give us your spiel.
Yeah, sure. So, there's obviously a host of things that we'll do for someone who comes in with that sort of, knee pain that's, secondary to, a way to think of it as kind of that wear and tear on the joint. It's probably a little more complicated, of course, than all that, but that's sort of arthritis we're talking about. As you kind of alluded to, there's a bunch of things that we might do ahead of time, ranging from your over-the-counter type medications, your Tylenol, acetaminophen type stuff, up to the anti-inflammatories, traditionally your ibuprofen, naproxen, so your Advil, Aleve, Motrin, etc. And then even sometimes bumping that up into more the prescription territory of those same medications, so Celebrex, Meloxicam, those types of medications. And now, thankfully, actually, there's a topical anti-inflammatory as well that for the knee works fairly well. It's fairly superficial, so those creams and lotions can get absorbed readily and really can have an effect. And so Voltaren, which is the brand name, is recently been taken off of the prescription list, and you can now find over the counter. So that just added another little element to the arsenal here. And then, of course, moving on, as you mentioned, to those injections. So steroid, and for some folks who are reasonable candidates, if the steroids especially have sort of stopped working or don't work well to begin with, you can try those visco supplementation, the kind of the gel, or we've heard rooster injections.
Rooster injections, yeah. Go by many names.
That's it. And so sometimes, really with all of those, in my mind, what we're trying to do is sort of buy time, and maybe that time's indefinite. Maybe that's all it ever needs. And what we're really looking for is sort of a sufficient control of the discomfort to let you go out and live your life with a reasonable degree of satisfaction. Maybe it's not perfect. Maybe there's still flare-ups. But if we're getting by pretty well, it's, a rare thing or a mild thing, then that's it. But there are, of course, those folks who progress beyond that, and that's generally where, I step into the picture a lot of times. And then it's always a discussion in my mind, and actually sort of alludes back to what we were chatting about a bit earlier, but it's a discussion, and say, listen, we're sort of at what we've got now. We've exhausted pretty much everything we can think of non-operatively. I should probably throw in things like physical therapy and, canes and braces and those types of things as well. They can also be trialed. But if we're at that point, we're out of sort of the non-operative management options. I think we kind of have a very simple choice on some level, and that's sort of, we can live with it as is with all the ups and downs of it, or we can look to try to get it better with the surgery. But surgery does have its risks. They're low. They're, not zero, but they're, fairly low. And for some folks, maybe a little higher, a little lower, but in general, they're tolerable. And I usually equate it to the idea that you get every morning, get in your car, you turn the key in the ignition, or push the ignition button, I guess, these days, and you drive to where you're going. And we all kind of assume we're going to get from point A to point B without any issue or problem. But in the back of our head, we really know that there are certain risks that we're kind of implicitly taking when we pull that car out onto the street. And they could be very severe consequences. They're thankfully very rare again, and you could do everything right and still suffer those consequences. But the convenience, the benefit of being able to do that far outweighs those risks. And so for most people who are in that position where we're looking at, that all day, everyday pain that we just can't get better, on a day-to-day basis, and that's limiting your ability to go out and live your life, then the surgery can be a very positive step forward. Knee replacement especially is a long road back. It's much longer than the hip replacements, about twice as long. So I tell people to expect about a 6-month recovery. It's, it's not 6 months of being completely debilitated and post-op pain and all that. It's gradually getting better over those 6 months. But you're looking to get back to reasonable high-level function on a consistent basis. It can be that long, and some folks even a bit longer. But it's, an investment of time and effort to get the knee to a better place than it was when we started. And so if those, risks and benefits kind of weigh out, then I think it's something that's worth pursuing. But again, I think a decision everybody has to come to on their own. And my job is to help facilitate that, get you the information, get you the numbers, and kind of give you a feel for what to expect as best I possibly can. But at the end of the day, it's that patient's knee, it's that patient's life, and they know better than anybody the sort of the frustrations and what does or doesn't work, and also how they weigh out those risks. Some people are very risk averse, and I understand that. So some people hear that there might even be a small chance of something going bad. They're like, no, that's not for me. And they're right. I get that. For them and for their knee, it's not right. And other folks are like, yeah, this knee is absolutely miserable. I understand it's, a rare chance that something doesn't go perfectly well, but that's a risk I'm very happy to take if I can get the benefit of a happier knee. And so for those folks, I think the knee replacement's a good option. And then from there, of course, there's lots of different sort of subtleties about how best to go about doing that knee replacement. I tend to favor the muscle sparing, as you mentioned, so I think there's less collateral damage, if you will, from the surgery when we do it that way. Mm-hmm. One less muscle that we're detaching from bone that does not need to heal back after the surgery. And so it's one less source of discomfort and dysfunction right after the surgery, one less thing that needs to heal to recover from the surgery. And the numbers sort of bear that out in terms of the early going. A lot of folks will do better, especially in these first probably 2 to 3 months right after the surgery, in terms of decreased pain, improved function. At some point it probably levels out as to the more traditional approach, but it's a nice way to give folks, no pun intended, a leg up on their recovery. And then, of course, there's different models and different techniques. So you can do things like the robot assisted, which is
that's really interesting
technology
stuff.
And kind of really, hone in on that plan. There are things like custom knee replacements. They scan the knee and actually build your knee replacement custom to your bone. And so all of those have their sort of ups and downs, and for certain, degrees of deformity or wear and tear, they may make more or less sense. And so we certainly tailor that to the individual based on what their knee looks like and sort of what they're looking to get out of it. But, the vast majority of people will do very well with the surgery. And if they get to that point with those sort of parameters before we start talking about the surgery. And then the other thing for me, I think is very, very important that kind of feeds back into that is I know a lot of people get into that room sometimes and the surgeon says, oh, you need a knee replacement. And it's the knee that I would quibble with, life, death, loss of limb. Those are sort of knee surgeries, and even those are still the discussion with the patient. Geez, the bone's got to get back inside the skin. Let's do that surgery, get it fixed up for you. Whereas a knee replacement remains an elective procedure. It's something that may be a good option for you, and it's maybe something that's really worth considering. But for me to say that you need that surgery, that's tough. I really don't feel comfortable doing that because of that. Everyone being unique, and everyone has to make that decision with their physician and their surgeon on a one-on-one basis. And really, at the end of the day, the patient has the final say.
So you're not applying the device to the knee problems. You're looking at the knee problems to see which device might be appropriate.
Yeah, that's correct. Yeah, I think that's a great way to look at it. And so if you start thinking cookie cutter, okay, here's a knee, I've got this. What they say, everything looks like a nail, and all you have is a hammer. So
yeah, right.
Things in the corner, right? It's not quite right. So yeah, yes, I can put a knee in somebody. Where's that person? I got to go find them. I'd much rather, take a look at that person individually, have those x-rays up while we're talking, really sort of, point out my thought process to that patient while I'm saying, listen, this is what I'm seeing here. This is what I'm seeing there. This is what all that means in kind of plain English, I hope. And then they can kind of, really become an active partner in their care. And then we can kind of make that decision to some degree together, but again, with a lot of input, really the final word from that patient saying, yeah, okay, I like that. I like this idea. That makes sense to me. Okay, that's what I want, and we can kind of really get them, I think, the best outcome with that approach.
Yeah. Excellent. Well, between the two of you, we can do some innovative things on this program. Occasionally a new device will come out that's like a revolutionary device that's going to eliminate all these kinds of things. Those are the kinds of things I would like you guys to bring to this show.
So, and you bring up a good point there, and Dr. Johnson was close to this. So about the hip replacements and the metal on metal issues. Sometimes we do need to be careful with the newest, latest, and greatest, because if it's not adequately tested, how we were talking about earlier, with vaccines and whatnot, you don't know some of these downstream consequences. And for example, Dr. Johnson can probably talk about this more. There's this 30-year knee where in the laboratory, this knee is supposed to last people 30 years, but we're humans. We don't behave like the laboratory. And so, yes, they can claim that, then it's going to be fine. But until you actually see it in human subjects, who knows? And so I always warn people to be careful of the latest and greatest, make sure it's adequately researched.
Right.
Yeah, Dr. Johnson, any thoughts on that stuff?
Yeah, oh yeah, no, that's sage advice. I think the old saying is you don't want to be the first one on the boat, but you also don't want to be the last one on it either. So if there's something new and interesting happening out there, great, look into it. Let's take a look at it together. Let's find out what that technology has to back it up in terms of the science. And even then, there's science and there's science, and so sometimes it looks good and promising, and then it sort of fizzles. And I think right now people have gotten a very heavy dose of that, looking at the COVID stuff, for instance, right? Which is the latest, greatest treatment coming out every week, and some of those have really worked pretty well, and others have kind of fizzled. And so
there are like 150 meds under trial.
Yeah, right.
Oh, really?
There you go. Right.
I do a monthly electronic newsletter. I do a network group of about 800 people. As I send out this newsletter, and I always put a couple of articles in there. And one of them is very interesting because it's talking about how they are going to distribute this vaccine.
Mm-hmm.
And who's going to get it? Are the first responders going to be first?
Yeah.
Are the people over 80 going to be first?
Mm-hmm.
Are the this, the that? If there's a charge, a number of people won't take it. In fact, I didn't read it, but I saw a little thing in AOL Mail this morning about the number of people who will take the virus or the vaccine when it comes out.
Right.
And not a whole lot are saying yes.
Yeah, it's a very low number, as I recall. I think that the highest I've heard was around 60% or so.
Yeah, right.
Yeah.
Something pretty sobering. And I think that's a great point, right? So you have this idea of like, people think, okay, great, the vaccine, as soon as it's done, problem solved. But it's really just the beginning of solving the problem.
And that's what we need to tell the public.
Mm-hmm.
Okay?
Yeah.
And that's why the show exists. It's called a forum. And the definition of that word is a gathering place for information. And what better place to do it and inform the community of the things that are going on in a great variety of ways.
Yeah.
So we have a good venue here.
I think you're right, and especially in these days where there is almost a deluge of information, it's extremely hard to process and vet. And I mean, just your day to day, obviously, and the average person is just trying to get through their day, much less digest all of this. And being able to offer a little bit more, I think, of an informed, at least, within our corner of the world, of course, insight onto some of those things. But this has got real promise. This is kind of hype. And, I think it can be very, very helpful for someone who's trying to, just deal with all that information coming at them and be able to get it out there for folks to be able to think about and apply to their own lives.
And also any device that's implanted in the body, you have a curve. It might be that the earliest one would come out at 5 years, or the other one would last 50 years. Mm-hmm. We need to look, what's going on. I had a mitral valve replacement 16 years ago, and the doctor said, well, it's going to last about 16 years. Mm-hmm. And I said to my cardiologist, I said, am I up? He said, come on. He said, you know about a bell-shaped curve.
That's right.
As long as it ain't broke, don't fix it.
That's right. That's another one we use a lot.
Said,
yep, it's not broke, don't fix it.
He said, you'll know when you need one.
That's it. Yeah, we can always make it worse. We can't always make it better, So you're right. I tell you, that's a great piece of advice. And I think you're right. That kind of goes back a little bit what Dr. Joey here was saying about the 30-year knee. You've got these sort of laboratory settings, which are, listen, very well designed, and they're trying to replicate in large numbers what might happen to that knee. But it's a very different thing to go from a lab and literally it's a machine that just cycles the knee a bunch of times. It looks like like a canning machine for all intents and purposes, just kind of cycle.
Yeah.
But then you put it in someone's actual knee, and that person is going out and living an actual life. And how is it going to impact their day-to-day function? And how does their day-to-day activity impact the knee? It's a much more complex question than something that can be just sort of guesstimated prior to. And unfortunately, that is how we get this knowledge sometimes, is by misadventure as much as by success.
And that's what our job is, to inform patients of that very thing. Mm-hmm. Get the information. To me, information takes the worry away from something. Mm-hmm. I have a pain. I don't know what's going on. Am I going to die? And I have, bubonic plague, something. Right. Guy says, no, you have a cramp in your leg. Oh, okay.
Right.
Once
you're not kidding. A lot of it's the anxiety of not knowing. It's sometimes worse than even just getting a name for it. Once you have that, you get a lot of power over it. You can start to wrap your head around it. Up until that point, that just nebulous. It's out there. It's something. I'm with you. I get that weird pain for the first time. I'm staring at the ceiling and I think,
Paul, my area right now is Alzheimer's and dementia. And you would not believe the calls I get from people whose physicians never explained anything other than your husband has dementia or has Alzheimer's.
Yeah.
And then you go home. I had a lady who called, honest to God, I got to tell you this. I called, I don't know, 6 months ago or whatever. And she said, I got your name from the Office of Aging. And she said, they said, you're the man. I said, okay, what can I do for you? She said, well, my husband just got diagnosed with Alzheimer's. And I want you to give me the name of a good therapist so we can get his memory back.
Oh God.
And I said, ma'am, I said, right now, we're not going to talk about your husband. I said, you and I are going to have a come to Jesus talk. Are you ready? Let me start out by being gentle. He's going to get worse. Now, here's what we need to do. I had a social worker go to her house. I had her go to a support group. I had her look at ALs with secure units, et cetera, et cetera. The knowledge took such fear away from this woman. But nobody talked to her about that up to that point.
That's heartbreaking.
Yeah, you know, so, I mean, that's kind of the mission. I mean, I'm glad to use that as an example, but I'm sorry I had that kind of example.
Yeah.
You know?
Yeah, that's it. No, I know what you're saying, and I unfortunately, you know, you go through training and you bump into folks along the way who are kind of that sort of personality, and you know, they say hello from the door, they're happy to throw a diagnosis at you, they don't explain it, they don't back it, they don't translate that into English, and it's, you know, a huge part of that, I think, is making it accessible to someone. Listen, this is what's going on, and this is why it does this, and this is why this treatment does or maybe doesn't work for you and for your problem. And you know, really unpacking all that, I think you're absolutely right, gives people such a great sense of understanding and confidence about what they're dealing with. It really demystifies it.
And you and Joe are separate from a bunch of people because you look at the patient and find out what can I do to help this patient with his melody, rather than, oh boy, another knee, oh boy, another series of injections. No, you know, you look at the humanistic side, and believe me, as a patient, that is most of what I want. I know you're proficient. Yeah, you're board certified. That's not the problem. Are you board certified in communication? And you know that's funny because
no, but you're right. It ought to be. It ought to be a big part of it, and it's not. You're right. It's just okay. How much knowledge have you crammed in your head? You know, how good are your skills? You know, with the procedure or the, you know, whatever it might be, how your diagnostic skills. That's great. Those are obviously important things, but you're right. There's a whole other half of that, if not more than half, that deals with, okay, but this is a person sitting here next to me. This isn't a diagnosis. This isn't a chart. This isn't an x-ray. It's someone I got to try to make feel better about their ailment and get them more functional, get them happier with their life. How do I do that? You know,
and that's not what you learn in medical school.
Unfortunately.
Yeah, it's
You should have a
unfortunate.
course in
Yeah.
communication. You should have a course in business management.
It's tough. There's so much to tackle, so much to learn in medical school.
I know, but
but you're right.
Another
yeah.
4 years, you'll be able to.
Yep, exactly.
Yeah,
And
but
yeah, tack on more years. Yeah, another 4.
Those are things that, yeah, but well, hey, you're doing a great job. You're a great worth in what you do.
Yeah. All right, 5-minute countdown. All right, we got a few more minutes. Yeah. Oh, one thing that I will chime in about, Dr. Johnson was talking about, you know, the knees and all the different, you know, procedures there and treatments and whatnot. You know, there is that other kind of gray area of things that don't work with as high as a percentage and maybe are not quite the gold standard of treatment. So, you know, people may have tried, you know, everything like he talked about, like the therapy and the injections, and maybe they're not ready for surgery, but they want to try something a little bit off book. Well, then that's when we're thinking about things like platelet-rich plasma, PRP, the stem cell injections. There's other procedures like nerve burning procedures, something called COOLIEF, or maybe just some alternate salves and ointments, or things like just chronic pain management. You know, we won't go too deep into those, the stem cell injections and the PRP and whatnot. We do offer them. The big problem and the hang up tends to be for a lot of patients that the insurance companies don't cover it. And those can be expensive injections, you know, $1,000, $2,000 injections. Yeah. But it is something that we utilize. And I'm always, you know, very upfront, very honest about that, because, you know, it's people's hard-earned money. It's coming out of their pocket. Right. And well, the research says that it's only so good despite what people think. That's another thing that Dr. Johnson and I kind of address with patients too, bringing up that part of it.
I'd like you to think about at some point doing a seminar of Stem Cells 101.
Yeah, there's a lot of bad information out there.
Yeah, right. And yeah, but there's still, you know, very few people could explain to you what stem cells are, what they do, and I think that would be great for us to clear the air a little bit.
Yeah, definitely. Yeah, maybe one time, maybe next month or the following month, we'll have to, say this is going to be kind of the regenerative medicine type talk. PRP, stem cells, amniotic cell injections, all of those things that are a little bit off the book.
Yeah. Well, we've only got a couple minutes left. Dr. Johnson, thank you so much for your input today. It's enlightening for me to hear you.
Yeah, we'll have to have him back on again. I think you did a great job.
Sure, why not?
I greatly appreciate the opportunity. It's absolutely my pleasure to be able to speak with you folks. I
Well,
absolutely enjoyed
Joe's the
myself.
one that has to suffer. He has to come down here. You're sitting there with your pajamas on, having a cup of coffee.
Yeah, that's one of the reasons to go into the doctor world. You get to wear pajamas all day. You want to wear scrubs. But if you want to find Dr. Johnson or myself, you can find us at Florida Orthopedic Specialists. Again, our telephone number is 335-4770, 335-4770. And again, we have the office in Port St. Lucie and in Stewart. It's walk-in. We see people same day, so call us up or walk in, and for the most part, we can see you same day. Yep, we're there.
Good.
I'll be there today. So will Dr. Johnson. I'll see you in a few minutes when I drive up there.
Where's it in Stewart?
Stewart, it's right next to Willoughby Golf Course.
Okay.
The exact intersection
That
is more off
plaza?
off of Indian Street
Right.
and Willoughby Street.
Right.
So it's just a little bit west of Highway 1 and Indian Street.
And it's a nice complex up there.
It is a beautiful area.
Very
It's
nice.
nice being in Stewart. We have a
Yeah.
lot of patients in Stewart too, Hope Sound, Jupiter, and it's right off the highway too, because
Mhm.
that's not far from Canner, and so you can easily jump on the highway.
But you still have a beautiful system in Port St. Lucie.
Oh yeah, yep.
That office complex, the surgery center.
Especially now with Crosstown, it's so much easier to get back and forth, to wherever
Exactly.
you need to go, to the
Exactly.
highway or whatever.
Well, that's it for us for today. We'll be back next week on The Forum.